So first of all, Kevin and I would like to thank Sue in her panel for volunteering to come to us with a discussion of health information exchange and interoperable EHRs. Most of the people on this podium need no introduction. But to my left, Sue Miller. Well, it's true. I don't know everybody on this panel, do I? I will assume that the gentleman to Sue Miller's left is Michael Zager. No. Oh. Who are you? Oh, Joseph McClure. Well, Michael Zager must be on the end. Yes. Doreen Espinosa? Yep. No. I know who Ruth is. Doreen is after Ruth.
That's right.
Who's on first? And of course, last but not least, Ruth Carter. Ruth Carr. So, I take it away, Sue.
Thank you, David. Thank you. We are sitting in the order in which we're going to speak. I'm Sue Miller. Joe McClure is an attorney inside Siemens. He's going to talk about the structure, what business associates can do for an HIE. Ruth Carr is also an attorney. She was the first HIE coordinator in the state of Georgia when the money flowed from ONC. Doreen is the Chief Business and Development and Privacy Officer for UHIN. UHIN is not a hybrid or an OGA, but it is a complex entity. It is a clearinghouse, an HIE, and a HISP. And Mike Zagar is a director for the New Jersey Regional Extension Center. And we are going to talk about what security can do to help in HIEs and EHRs, but what it also might not do. We've all been talking recently about today and yesterday that we're in a mess. We're in the middle of this paradigm shift. We're a work in progress. And you're going to hear some things different from what Kirk Nara may have said this morning in that, HIEs are not using HIPAA. So I'm going to set the stage, and I'm going to change there's the agenda. We've been through that. We have 4 federal agencies involved, basically, in EHR and HIE work. We have the Office for Civil Rights that writes and enforces the HIPAA security rules and its requirements. We have NIST, which has written twice now. They have an update to Special Publication 866, which is the resource that the federal agencies must use when they deal with the security rule. And as several of the other people who have presented said, that indeed it is good guidance for the whole industry. It's what I tell my clients. We have the Office for the National Coordinator that has funded the statewide HIEs to a great extent. In Georgia, they received a total of $15 million. And the Centers for Medicare and Medicaid actually write the meaningful use regulations, and it includes the risk analysis and encryption from the security rule. So we also have a bunch of new issues that you've been hearing about. We heard about cloud yesterday. We've heard about mobile tools all through the meetings. We've heard about bring your own device to work. I heard a new one yesterday, CYOD, choose your own device. And then we've been hearing about big data. And under the new omnibus rules, an HIE becomes a business associate, and they're responsible for all HIPAA security, which we just heard David say. And we have some industry and federal help. We have open source tools that everybody can have access to. HL7 has actually made their tools open source. We have Direct and Connect, which have been developed by the federal agencies and are free to the industry. We have some help in HIPAA security. We have risk analysis and assessment, policies and procedures, security controls, training, and the compliance plan that we've been talking about. So that's mine, and the next one should be Joe's, and it doesn't. There we are. he said, go ahead.
Oh, okay. Okay. I'm going to spend a few minutes and just talk about the regulatory and oversight framework of the HIEs. To some extent, this is going to be a continuation of some of the concepts that we just discussed with David and Kathleen, and in particular the business associates. So we're going to talk a little bit about that question about who is a business associate and how an HIE has to consider their role in the relationships they have with their stakeholders. I do have a slide that discusses the omnibus final rule impacts to business associates. We probably won't discuss the finite details of that because I think we've seen some of it. But here and there, I do have some additional concepts I think would make sense to discuss. And also going to touch on the business associate agreements and the considerations that need to be taken for that. And we'll wrap up with some comments about HIE governance. So we talked in the last session about the fact that the omnibus final rule clarified some concepts about who a business associate is. There were some things particularly that were in the HITECH Act, and we saw that HIEs were specifically named as business associates. That flowed through to the final rule. So I don't think that's any surprise to anyone. So an HIE has to obviously consider what their relationship is in terms of their stakeholders and who they're processing data for and excuse me, what they're doing with the PHI. If they're a repository of any kind or if they are merely facilitating the exchange of the data. And also, and I don't think I can stress this enough, but the impact of the subcontractors becoming part of the definition of business associates, I think it's something that all entities really need to take a hard look at, whether you yourself are a covered entity and you have to consider who you're doing business with, or you're a business associate and you have to consider who you're doing business with. That is a very significant aspect, I believe, of the HITECH Act and the final rule, because the business associate definition to me is just something that it keeps growing. So as far down the line that we go with subcontractors, these obligations basically just bring these entities into the definition. And in my experience, I've actually seen this in a couple different ways. I've seen some entities that they don't realize that they actually would be considered a business associate. They may have signed BAAs in the past, but they haven't even really paid enough attention to what's going on to understand that now you are a business associate. You're subject to direct liability for many of these requirements under HIPAA security and privacy. So there's that aspect of it. Then there are subcontractors that maybe in the past they might have considered a business associate agreement, but now they're taking a second look. They actually are aware of the regulatory impacts, and they are taking a second look at, well, do we really want to be defined in that world? And I think this goes to the question in the previous session about whether or not there's been a chilling effect. I know I personally had some contract negotiations where I can sense that the vendor I'm working with does not want to be labeled a business associate and will try to find as many reasons as they can not to be incorporated into these obligations. And we do get into this conduit versus business associate argument from time to time. And as David pointed out, it's one of those things that depending on what is actually happening with data, we may have to look at further. But I really like the concept of persistent custody that he reminded us about, because, from my perspective, excuse me, and this is my opinion, I look at the conduit exception as not just the persistent custody, but I go back to the original guidance that HHS put out about the conduit. And in that guidance, they basically said that it's a situation where access to PHI is not contemplated, and the likelihood that the data will be compromised is low. So to me, both of those things have to be there. And even though you might have situations where someone could say, well, I'm not going to have access to it, well, you have knowledge that it's there, or there may be other factors that might create some concern that the likelihood of compromise might be there to some extent. And I don't think those are things that are clearly defined. So obviously that's something that all entities need to take a look at, and particularly HIEs as they're trying to define what their role is in the exchange of information. So then what did the final rule do? This slide is sort of a one-page summary of the key things that the High-Tech Act and Omnibus Final Rule impose on business associates for direct liability. I'm not really going to go over each one of these because I think David covered them pretty well, and you may also be seeing bits and pieces of this with some of the other presentations. But clearly, the business associate and in terms of the HIE have to really consider what they're doing with the data, and in particular with the privacy rule. The obligations that are in the business associate agreement are ultimately what's going to establish where some of these obligations arise. So if the obligations in the business associate agreement and any underlying service contract involve let's say restrictions that on disclosure and providing some services around that, the HIE may see that as something that they will have to comply with. But not just that, there are also opportunities. The HIE can look at some of these requirements, let's say around the restrictions, as enabling, for example, consent management in the way information is shared across the exchange. So there are ways to look at the various changes and the obligations that the covered entities have and the business associates have as far as what opportunities are there. In terms of how the relationship is defined, in the HIPAA world, everybody I think is relatively familiar with the business associate agreement concept. One thing I will expand on excuse me, is that the Omnibus Final Rule outlined the specific things that have to be in the business associate agreements in order for them to be compliant with the final rule. These changes really didn't, they were not any different from what the proposed rule said. But, we in the original version of HIPAA, we had a series of things that have to be in a business associate agreement in order for them to be compliant. And then now, with the final rule, there are some additional things that have to be in there. So the agreement has to state that the business associate will comply with the security rule obligations, and they're subject to those, subject to that enforcement. Most of the business associate agreements already had some reference to the business associate's obligation to do those things. And also we have the obligation to report the breaches under the breach notification rule. So that is, that's got to be in those agreements, as well as the fact that the business associate has to have business associate agreements with subcontractors. So that's where that chain of trust is created. And as far as a regulatory obligation, the business associates have to have those BAAs with the subcontractors the same way that the covered entity does. And so that needs to be reflected in the agreements as well. And finally, there's a piece that needs to be there, and that is if the business associate is going to do anything on behalf of the covered entity for to help the covered entity comply with the privacy rule, then the agreement has to state that the business associate will do those things in compliance with the privacy rule. So that's another key thing. So those four things have to be in these agreements to be compliant. There are other considerations that not just HIEs but all organizations are going to need to consider, and that's one is whether or not the relationship that you have whether upstream or downstream, creates an agency relationship. That is also, I think, one of those things that is a key thing. In addition to subcontractors now being part of business associate definition, the agency relationship is something I think people should take a long, hard look at, because if your downstream entity is acting within the scope of agency, then you can be liable for their acts or omissions. So that means that whenever it is that they discover a breach, that means you will be deemed to have discovered it when they discovered it. Or if they violate something, that violation could be imposed on you because they're acting as your agent. And the thing about this is, and there's a whole discussion about this in the preamble to the final rule, is that this will be based on the federal common law of agency. So it really doesn't matter what your agreement says. Your agreement could say, we are both independent contractors of each other and we're not agents. But if the nature of the relationship is one that the covered entity can exercise interim control over the business associate, and as things arise, the covered entity can say, you'll do this and you'll do that and you'll do as I say, then it's very possible that the agreement will be, or the relationship will be deemed one of an agent. So it's again one of those things that all entities need to kind of keep an eye on. And I won't go into the implementation timeline. David talked about that. But another thing that we see, and I don't think that HIEs are immune from this or will be immune, is that in many of these business associate relationships, I see that there's also some focus on the type of security that will be imposed on either the business associate or the various entities that are participating. And so we see these in a number of ways, but a data security agreement is usually the most common way. So in addition to the business associate obligations that state you're going to comply with all of these things, entities want to also try to establish, well, how are you going to comply? What is it that you're going to do to keep the infrastructure secure and things like that? And so those are other things that come into play, and you need to consider those. And finally, I'll just talk briefly about the fact that there is a framework that ONC has developed on the governance of the HIE environment. This is documented. There's a resource. You can see it on ONC's website. And basically the goals are to increase the interoperability, maintain the trust level of the participants of the HIE, and not just the participants in terms of the entities, but there's also a focus on the trust of the individuals whose data is actually being shared. And obviously, from the interoperability perspective, we want to decrease costs and reduce the complexity and things like that, and make it easier for entities to communicate. So you can go to the website and check that out for yourself, and there are several resources you can find online. And that's all I have for now. Yep.
We have a teleprompter rather than looking at the slides, so I've got to move the water decanters. As Sue said in introducing me, I was the State Health Information Technology Coordinator for the state of Georgia. I am not now, and I'm not speaking for the state. I am speaking for myself, so any blunders or mistakes are all mine, no one else's. I'd like to review some special issues that pertain to health information exchange organizations in real life. The HITECH Act a few years ago defined business associates to specifically include health information exchange organizations, HIEs, HIOs, that provide data transmission of protected health information to a covered entity and that require routine access to protected health information. So, as Joe has well laid out for us, HIEs and HIOs must comply with all of the security rule and are subject to the enforcement rule if they are business associates under the law, the regulations, and high tech. There are various models, terminology that has been used for a few years now about HIEs. The ONC used these terms, for example, the elevator model, the capacity builder, orchestrator, public utility. Those were given as not confining but illustrative models. And they varied from a mere conduit to a full-fledged exchange of information with data storage, the record locator service, master patient index, and provider directories, so forth. Some models are called centralized or federated. Those are, if anyone labels the HIE models these days, those are commonly used. Centralized or federated tend to be top-down sort of control. NIST describes HIE context in some excellent documents that, again, are illustrative. There's an ad hoc model or an ad hoc context with NIST, a regional, multi-regional, and, of course, nationwide. So with all of those, the big issue for us today and moving forward is whether the HIE, HIO is a business associate. So we look back at the definition, parse out the words, and look at whether they transmit electronic protected health information. Do they require routine access to that EPHI, or do they have routine access to the EPHI? Now, pointing out to you the difference in require routine access and have routine access is coming from me. This is not necessarily in the regulations, but I will tell you that as I went through and did the word search in the preamble, I found that the term have routine access was used approximately as often as the term require routine access. So I think, as David Holzman told us before, the persistence of the access, the persistence of the custody of the EPHI is critical. It's not the one-off, we're passing this through zip, this is a FedEx delivery and we're out of here. It's the data storage company, for example, that has routine access to it. About HIEs and HIOs, an important thing they must and are engaging in is continuous monitoring and adaptation to changes. Now, earlier today, Director Rodriguez talked about changes in business operations. That's a big characteristic of HIEs and HIOs. And I think you see that in a lot of even the terminology. At one point, provider directories were not called that, they were called certificate authorities, and such as that. So you've got to stay agile and flexible, I think, to work in this space, and appreciate and thrive on the dynamic, evolving environment, because it truly is fast-changing. The business models change, the services that are offered change, the priorities in the actual business operations will change. Staffing changes, I'm a good example of that. Innovations in technology also are an important part of this environment. Changes in the business often mean value-added services, more shared services. There's now more commonly cloud hosting, clinical utilization review, quality improvement review, patient safety activities. Patient safety organizations, of course, are an active part of this. Personal health records, PHRs and PHR vendors now may very well be connected to the larger statewide or regional nationwide exchange. Also, other changes are in more stakeholders, more participants. I think not only with healthcare providers, but as we've heard and we're reading and seeing more and more, we're looking at patient-centered care, consumer-mediated exchanges. So patients and families, not covered entities, not business associates, but patients and families are important participants in this exchange and have their own unique issues about privacy and security for you to consider. Back to basics. We have to remember that as business associates, implementing the security rule, HIEs and HIOs have to administer safeguards, of course document them. We have to document all of our compliance activities. Physical safeguards, technical safeguards, and among the technical ones especially, we've talked a lot at this conference about encryption. In accordance with the HHS guidance based on NIST expertise. Some of the challenges in HIEs are a lack of agreement on policies for security and just business operations, lack of agreement about the technology and the exchange mechanisms. Some participants in an HIE, HIO will differ about whether they want to have patient opt-in or opt-out, and about the customization of some of their patient access. There are a lot of concerns about legal liabilities of the participants, and especially now that HIEs and HIOs are more and more likely to be business associates. They need a common set of business practice, organizational trust agreements, the governance framework, as Joe talked about, the ONC is working on and helping to fund and stimulate, promote nationwide. More than ever, this has always been the watchword, the passion behind HIEs and HIOs is collaboration. It's public and private sector. It's often, what's brilliant to me is to sit at the table in an HIE organization and see competing hospitals reach across the table, shake hands, say, yes, let's do this. Very tough now that they have to add some higher stakes, perhaps higher risks. They have to say, yes, let's do this. We together will do a security risk analysis. We will identify our vulnerabilities and we will address them. We will have our governance organization, our HIO governance body, responsible for compliance with the HIPAA security rule. So collaboration is important more than ever. You all are probably aware that we had a success story about HIEs coming out of the dreadful tornado that hit Moore, Oklahoma this week. Among all the disaster stories, part of the success was that an HIE that had been in operation for about 7 years had backup records stored as part of its services. They had backup records of 2.4 million patients, securely stored in a facility built in the side of a large hillside in Kansas City. So those were safe, even though the Moore Medical Center, for example, was largely destroyed, evacuated. Unlike a lot of other national disasters we've had in a number of years, they did not lose their patient records because they had backup records. Their patient records were all backed up by that HIE, by that Regional Health Information Organization. So that's something to celebrate for HIEs and HIOs. Resources, you've heard about some of those, you know those. These websites are ones that I had referred to often. Go to, you probably should bookmark virtually all of these. Go to them often. They are actively updated. You'll find a lot of help from OCR's websites we've heard about, from the NIST website, of course, and also from the ONC when you're looking at HIE information.
I think that means it's my turn. Just to... Okay. Oh, oops. It went too far. Go back. Yes, please. One more. One more. Okay. Before we get started, let me just give you about a 2.5 second introduction of UHIN and who we are. UHIN started 20 years ago. We were one of those things called a CHIN. So you can add that to your acronyms. We're a Community Health Information Network. And we started out by exchanging administrative data. Now, this was pre-HIPAA. This was pre-transaction. This was pre-everything. So, we started out a long time ago, and we did, like Ruth suggested, we did a lot of collaboration. And that really pushed us forward into who we are today. Prior to 2012, we were a conduit, also known as a VAN, because we didn't fool with the data, we didn't save the data, we didn't do anything with the data other than pass it from place to place. We were the pipeline, if you will, for data. We made a business decision to become a clearinghouse, so we became a covered entity in 2012. And then we got audited. I'm just saying that because it was really an interesting time. And also there was the Medicaid breach. Just slight side stuff there. Anyway, so we've had the idea of exchanging data for 20 years. We began our HIE about 5 years ago when the cooperative agreements came into play. We were one of the beacon communities that was selected. We had been working on doing some sort of an exchange 5 years prior to that. So we've been working on this for a very, very long time. And what's been nice is that we now know what we are in terms of privacy and security. Now, I have to tell you, our commitment to privacy and security was carried all the way along. So back in 2002, after we'd been running for a while in the state of Utah, we decided that we would behave as a person or an entity that was covered by the privacy and security rules. So we've been doing this for a really, really long time. And that's why, you know, we have an opportunity to explore what UHIN has done and what UHIN will continue to do as we move forward with the rules. So now we know we are a covered entity and we are a business associate. So that was the nice thing, and that's one of the first things as you've heard my colleagues and others speak about. What are we? And UHIN has decided that we are definitely these two things because the rule says so. So it was kind of nice to not have to think about too hard. Sorry. Now, when you think about it, I always say the data are the data are the data, okay? I don't change my name because I'm having a claim sent versus I'm having a service provided. So while the data are the data, and you're going to have my name and my address and potentially my social security number, even though everybody says, no, you don't have that. Sometimes they do. So you have this information, but how you use the information is where you begin to kind of tease apart the things that you need to consider or the things that you need to do. In a clearinghouse situation, you are taking information and you may be transforming it from a non-standard to a standard transaction to send this information back and forth for generally financial purposes. In the HIE world, what you're doing is you're taking some of that same data because you still have my name, you still have my address, and you're going to use that information to provide treatment. Now, I say that in general because that's what HIEs were initially started for, to get treatment information back and forth. One of the things that has become very interesting is now there's this thing called research. And a lot of people have noticed that HIEs have data. And, you know, that's something you really need to consider because the requests are coming fast and furious. The idea that you may have access to data is something that you want to consider and consider very carefully. And you want to consider it early on. How do you want to deal with this? We have an entire committee that works on this with a whole group of lawyers that works on this. So those are things that you want to consider now before you go too far down the road. Or if you're already down this road, share your experience with others. But the idea for the data truly in an HIE is for treatment purposes. Next, please. Now, while the data are, again, they're same person, same address, same phone number, they're not used the same. The purposes are very, very different. And so they are, in my opinion, the administrative data is a subset of the clinical data because you can't create a claim or a bill unless somebody gets seen by the doctor and some sort of service is delivered. So you have that subset that's really the financial or addresses the financial portion of things. While the clinical data, you have more robust data. You have results of your laboratory work. You have office notes that talk about your symptomology. You have your care treatment plans, and you have the medications or any kind of pharmaceutical treatment that you might be receiving. So again, based on all this service data, you will get some sort of financial data. And what this does is this creates different roles inside of the same organization. So you now have people that will deal with the financial end of things, like the office manager. And the office manager may have access to all of the data in the office, whereas the billing clerk may only be dealing with the billing information, and the front desk receptionist may only have access to eligibility information. So what this means in terms of security is you have different roles that you need to address, and you need to help people understand that they are the vulnerable position for your organization. Now I flip over to the HIE side. Guess what? I have doctors and nurses and allied healthcare professionals and pharmacists as well. So now we have to give all the information all the time to all these people, okay? Because they want to see the entire record. They don't want to see just, the name and the address. They want to get the entire list of what's going on here. However, in these roles, while your nurses might be able to put together or data enter the prescribing information, the prescription may only be approved by the provider. So again, you begin to tease out these roles, and you begin to have to understand that there is a certain amount of security that needs to be addressed with each of these roles. And as I talk about this, I want you to think about your security analysis. Okay, you want to look at each one of these roles. You want to follow the data and see who touches it, for what reason, and what is their complete access and ability to change, to delete, to alter, and to create. So you really need to consider these things in your security so you understand how to appropriately address not only with technology, but also with your policies and procedures. Because of the different usages, you will need to look at how it's done. In other words, what's the workflow? And you also need to decide what is the time that you need this information in. I generally don't need to see claims transmitted immediately because nobody's going to be impacted in terms of, life or death situation. However, when you begin to look at an emergency room situation, or if we think about what happened with the tornado, they needed information quickly. There were people that were not conscious or able to speak to themselves, but those records that were saved in Kansas needed to be accessed immediately. So you have to have some real thoughtfulness placed into how you administer security, and how often is this data used, and at what points in time does it need to be received. Next slide, please. So one of the things you really need to do, and I can't stress this enough, I know this is the weakest point in many of the audits that came to be, but you have to do a risk analysis. You really need to know where your data is, what's it doing, who has access to it, and what kind of time frames do you need to recall this data in. You also need to understand the security for the access. Based on the roles that you have, based on the access that's needed, what are you going to do? Is it a one-size-fits-all? Generally, no. And I know that presents a challenge to those of you that are technology folks, because now all of a sudden it's not just everybody does this thing all the way, all the time. No, you have to make it fit the situation. The storage and retrieval, that's been a big question. Am I, if I just store the data and it's encrypted and I don't have the key, am I really responsible, to be a business associate? Joe said something at one of the conferences that we presented at, and he says, if you're that sure that it's that secure, then you're a BA. Just sign it. It's okay. And I thought that was great. I just went, wow, something in my arsenal for someone who gives me any grief about it. But it's true. If you are committed to that level, if you've got your SSA E16, or if you have all of your certifications, what's the scare? Okay, you're going to find more collaboration if you will admit to the fact that you are doing the very best that you can. Again, remember what Leon said, there's the two things. There's basically the gross negligence of not being able to meet the rules at all, and also for access. So, think about it in those terms. As far as the information that's changed, that's something else you have to consider. In a claim world, you generally don't go in and fool around with a claim online or anything like that. You will generally, there's a workflow that allows for you to send a claim and then to send a corrected claim and note that it is a corrected claim. Okay, that's how the administrative world works. However, that's not the same in the clinical world. In the clinical world, you can go through and fix or change or alter that record, and that kind of stuff has to be understood. The question came up, did somebody see the data or not see the data? That's question one. Question two is, did they change the data? Can you audit that? And that becomes very important. I'll just give you a real quick story. There was an individual who thought that her information had been compromised by someone at her work. And she actually asked one of our member relations folks, can I get the log? And that person who works for us came to me and said, can we get the log? And I said, are they really going to understand it? And I don't, I need some more parameters. I don't just go get a whole log and give it to you, because if you've ever done an audit like that, it can get quite cumbersome and be, a couple thousand pages. So what I had this individual do is go through their privacy officer, have the privacy officer give me some information on what time frame, what were we looking for, who was it about, and some basic information so that we could pull something besides logs, so we could pull information that they could go back and do an audit, because I don't know whether, someone should or shouldn't be looking at this record or that record. As an HIE, I can only tell you what's happened, who's looked at it, if it's been changed or if it's been downloaded. But I don't know if that's a person that is allowed to do that or not. So we got the log back to this other privacy officer, and they were able to determine that, in fact, there had been no inappropriate disclosure or inappropriate access of this person's record. But that's the kind of stuff you have to deal with, and that's the kind of stuff that people are concerned about when they're using an HIE. So please make sure that your auditing is something that you can deal with and that doesn't get so crazy and wielding that nobody understands what's happening. The one thing that, everybody talks about data encryption, and I'm here to tell you, just do it. I mean, really and truly, just do it. I'm sure most of you have heard about the Medicaid breach. If the data had only been encrypted, okay? Seriously, guys. And the reason that it was breached was very awful. It was like Security 101 measures weren't followed. But, you go back and you think about it, and if the data were only encrypted, okay? So that's really what I think you should take away from this. And encryption's cheaper. Life is better than it was. Storage is cheaper. There's a lot of things that have come down in price. So, use what's at your disposal. And I think you're going to be well on the way as long as you keep your concerns and you understand where your data are and who has access to it. Next, please. So, again, look at your risk analysis, understand what's uber sensitive, what's mostly sensitive, and develop your policies, your procedures, and security accordingly. And the first thing really in mitigation of your risk, no matter how many policies you write, no matter how many really cool technology things you implement, the first and foremost thing you need to do is train. Okay, you got to train your folks. And I'll tell you, the auditors want to know who you trained, when you trained them, and what did that PowerPoint presentation look like. I had to give that documentation to the auditors. They really want to know that you did this. So I strongly recommend that you get a good training program in place. Okay? And that means you want to share it too. Share it with your business associates. There's no crime. Bring in those people that are contractors. You may have, a contractor here or a contractor there that's working in your office. Bring them in. Have them sit through the training. And then let your folks know that they can become personally responsible. There's nothing that hits home harder and makes more of an impression than looking at someone saying, if you goof up, you go to jail. Not me, because I'm training you. You're signing that I'm training you, and I'm giving you the tools to make everything work out properly. We have encryption on all our laptops, and when I did a training about the encryption, I told folks, look, if you don't activate the encryption and that laptop gets stolen, it's on you, not me, because I've trained you, I've provided you with the tools, now you have to use them. So really that's super important. As Joe mentioned and gave you a lot of information on, make sure those agreements say what they need to say. Make sure that you cover all of the high-level topics. Make sure that everybody understands what your responsibilities are. Meet the minimum security requirements that are set out in the rules, and use the various URLs that folks have given you. Ruth just gave you a bunch that are fabulous. Go, look, see, and keep up with them because it's important. And then make sure that you do include your business associates. Again, send them your PowerPoint training. It's not going to hurt. And if you want, invite them in. Make it something that everybody sees as an important thing to follow, because first and foremost, again, the biggest risk are your people. I think that's it. Oh, you've got it. Okay.
Good morning. Can you hear me? My name is Mike Zagar, in case you've forgotten. I'm used to going last with a name like Zagar, so that works out pretty well. In my former life, I was a chief information officer for several hospitals, so I'm very intimately familiar with HIPAA when it first came out. And privacy and security was one of the things that would actually keep you up at night as a CIO. But fortunately, I'm not here to talk about that. You've gotten great advice from all the other presenters on privacy and security. My focus is going to be on interoperability. I currently work for a regional extension center, NJ High Tech. We are the only regional extension center in the state of New Jersey, and our sole purpose in life is to get the providers in the state of New Jersey onto meaningful use. To do that, they have to first sign up with us, they have to get to electronic medical record, and then they have to achieve the quality measures and the thresholds in those measures to get to meaningful use. At this point, we have signed up over 7,000 providers in the state of New Jersey. 5,000 are already on electronic medical records, and we're about halfway through of the 5,000 to getting them onto meaningful use. So that tells you that probably forward-looking, half of that group, 2,500 or more, are looking at stage 2, and 2,500 or less are looking at still stage 1 and not as concerned about interoperability at this juncture as those who have already achieved that. So there are different perspectives that you'll get from different providers out there in the field based on whether they are large providers or small providers. The solo providers are really challenged if you're not familiar with what's going on in the field. They're very challenged by all of the changes coming down in many, in fact, all the areas, reimbursement, you name it, everywhere you look. HIPAA, compliance, meaningful use, ICD-10s is coming down that train is on the track already, and I don't think half of them are already looking at that because they're so focused on what they have on their plates. So they have a lot of things to do, and the more resources they have, the better prepared they are to really get there. One of the key factors that we've discovered and is probably all familiar, you're all familiar with that point, is that if you have IT people or at least knowledgeable people on your staff as a provider, you can pick up the pace much quicker than those who are not. So there's a lot of education that already has to go on. And if that's taken place by bringing in the appropriate expertise, then you can move much, much quicker through this process than those providers who are looking at understanding IT as well. So we are moving very quickly to try to get the providers, the rest of the providers onto meaningful use. Our target is to, by the end of the year, to get the rest of those 2,500 onto meaningful use, actually less than 2,500. Next slide, please. Actually, the slide you just went through, I didn't explain that as a regional extension center, not only do we help providers get into meaningful use, but we've developed certain products and services. So we actually we are a certified registry. We can submit data for the providers to CMS so they can get incentive dollars associated with the quality measures as well. We also help providers with ACOs and PCMH, patient-centered medical home, as well as we're going to do ICD-10. So there's a lot of help that they need. There's a lot of activity going on in all of these facets, and we're engaged in all of them as well. The stage 1, though, in terms of interoperability was quite simple. The provider had to try to test sending information to someone else, either another provider or a hospital or anyone that they can send information to. The benefit was to improve the quality and safety and reduce cost, although that's a little early in the game to measure all of that. That is the benefit associated with it. But all I had to do is one test to try to submit, and even if that test failed, they were basically passing stage 1 meaningful use. So the bar is very low. It was to get them familiar with the process of interoperability and exchanging information, because if we really don't do that, the whole process doesn't really work when you think about it. All of these wonderful electronic medical record systems out there disconnected doesn't achieve what we're trying to achieve in our society. So the connectivity and the interoperability is a must-have, and it's got to work. So they basically got through that process pretty easy, because it was almost it was a layup. It was very easy to do, and it was more or less a no-brainer. That process itself has been obsoleted with the rules that came out for 2014, Stage 2, which affected 2013. So it obsoleted that process, and we move on to Stage 2. Stage 2 raises the bar, as you all would probably know, associated with the stages of meaningful use. You start at the lower level, and you climb higher as you go. So the purpose there is to provide a summary care document and transmit that to another provider. The requirement has moved from a menu item in Stage 1 to a core item in Stage 2, so it is mandatory. You have to do it. And the eligible provider who does not have at least 100 transitions in or out of their office is excluded. So the low transmission processes or providers that are engaged in that are actually excluded from having to meet that measure. Next slide. So there are three components involved in this particular measure in Stage 2. The first one is that I can barely read it over there, so I'll have to turn around. Excuse me. You have to achieve 50% of the information has to be transmitted or sent to somebody, and that can be done on manual or electronically. The second part of that is you have to achieve 10% of the transfers in or out of your office electronically. That's the hard part. That's what will probably raise the anxiety level of some of the providers. And the other measure 3, or the third aspect of that, is that you have to transmit your information to at least one other provider with a different electronic medical record system. So the whole thing is being set up here to get the provider more comfortable with the interoperability, exchanging of information, to make it happen so they can really begin to see whether it works and what issues are going to come out of that. That will, as I mentioned, that will cause much more frustration on the solo providers, because they are challenged already with Stage 1, and Stage 2 raises that bar. The providers that are larger or they are closely aligned with healthcare organizations will have it much easier, because they have just much greater support staff and resources to reach out to. Next slide. So the issues associated from a provider standpoint with interoperability is, off the bat, they are very concerned about cost. Anytime you want to help them, the first question is that for free, or is there a charge for that? Rightfully so. The primary care providers, as you may or may not know, do not make as much in terms of revenue or incentive as the specialists, so they have a thinner margin to work with, and everything is associated with resources and the effort and the costs associated to do that. If they're not treating patients, you're taking away their time and processes from making a living, in a sense. So the first thing is cost, and there are HIEs out there that are going to that we've heard are going to charge per click, or charge as a subscriber subscription rate, or actually give it for free and make up the costs and some other aspect. The providers have to contend with, obviously, the implementation of this process of exchanging information, any types of interfaces. They will have to get their staffs trained and acclimated to the processes and get ready to send information to a different vendor, which they're not accustomed to doing. Additional training, as I mentioned, the workflow is a big issue associated with the practices. Actually, the word workflow is totally new in their environment. So to understand that when you install electronic medical record, you don't want to simply mechanize the manual process. You want to first go to refine your workflow and then go to a new process, which would be hopefully far more efficient. So they'll have to take all that into consideration for interoperability. That will help them through that process. I don't think it'll be as difficult as it sounds, but it is, again, another change in their practice and in their environment. Next slide. And security is an issue that you've already heard so much about by now that the providers will have to be cognizant of that, and we will work with any updates to any rules and regulations associated with privacy and security to help them. From an EHR vendor's perspective, the vendors actually haven't, in taking a short little poll before I got here, haven't not yet mentioned HIPAA, privacy, and security as an issue associated with what they're working on. They are so deeply ingrained right now in the formats of the information, data mapping. They all have unique requirements within their own systems. They interface to third parties, so they have to get that data correct. They're not talking yet about privacy and security. My suspicion is that they would probably later on in the year, as you get closer to this requirement, start to hit those walls and have issues and questions in more detail about how to handle certain privacy and security issues from a vendor perspective. They're certainly aware of it from stage 1, but stage 2 does raise the bar for them as well. So they know that their systems need to be up as much as possible for backups, even when the office is not in use. The standards that have taken place so far has really gotten, I think, interoperability off to a very good start. We've mentioned some holes or gaps in the process, but I'm convinced that being in this field for some time that we will get there. It's not a problem of getting there. It's an issue of when and how many will we bring along at the same time. There will be certainly those who are more advanced and there'll be laggards, but eventually healthcare is changing. That is the message that we get out to all of our providers, whether they want to go to an EHR or not. Healthcare, the face of healthcare has changed probably forever in terms of going to electronic medical records, and that itself needs to be a motivator. So the vendors themselves are concerned with the data content, the mapping, the information changes going from CCD to CCDA, and they have to provide an acknowledgement receipt. So the only way the provider is going to score on that meaningful use measure is that they get acknowledgement back that that transaction did occur. And that seems to be one of the gaps that there are no specifications for. So they will either do it themselves or they'll be reaching out for more information on how to do that. And of course, the security associated from the authentication as well as the logs associated with the information that was transferred, I think is going to play a key role in making sure that we can effectively ensure that the appropriate information got to the appropriate party. That is a huge concern, especially of mine, actually, when you think of the fact that trying to do this from step A to step Z and get it right is one thing, but what happens when a hospital changes the medical record or merges medical records and they get it wrong? How is that data then supposed to be corrected, and then how is it supposed to go back out to the providers who are depending on it out there in their offices? And how is that going to affect the patient? That could be huge if we don't get that right. Something to consider. Next slide, please. Well, this is the last slide, I believe, and it's very quick. So I just wanted to say that the certification testing, they've started that, and the information is available to them to get ready, but I'm not sure that they're all going to get there on time. I think the big plus in this entire environment is the interoperability work group that has worked so hard with many organizations to establish the appropriate standards. I call them universal standards, but any HIE is going to have to adopt to these standards as well as vendors to make all this work. And they've got a great start. They say they will be ready. The real question is, will the vendors be ready in time for 2014? I believe that's it. Thank you.